All right. So moving on into a quick review of Chapter 33, face and neck trauma. You like my nice, cool graphics here?
Pretty cool. Pretty cool.
Yeah, yes. In my world, we call that pimping, and it ain't easy. Um, I didn't even realize that my little star of life up here, it changes colors. See, watch. Look at that. Boom, red, blue. All right, part one. You respond to the scene of a motorcycle crash on a suburban road. The patient, a young male, was ejected from his motorcycle when it struck a tree. He was not wearing a helmet. The scene is safe, and 2 police officers are at the scene directing the flow of traffic. As you approach the patient, you note that he is lying in a supine position. His eyes are closed, and he is not moving. What should your initial diagnostic concern be about this patient?
Sorry, he's dead. Bye.
Doesn't
Check his
sound like
pulse.
doesn't sound like you're real concerned there, but okay.
Head injury and spinal injury.
All right. There's one big fact in that, and I noticed a little dissent in Eric's voice there, but he didn't have a helmet on, right? So
and he probably had shorts and flip flops on. So yeah, I'm fine with him being dead.
Oh wow. Oh, okay. I'm gonna have to cut that out of this recording. The fact that the patient was not wearing a helmet obviously dramatically increases his risk of mortality due to a severe head injury. That's got to be your primary concern, considering your general impression of the patient. He's on the ground, not moving. Don't just assume he's dead, though. You've got to take a look at him. You check a pulse, check his airway, manually stabilize his airway, and then look at your assessment and treat your life-threatening injuries. All right. Your partner maintains manual stabilization of the patient's head and simultaneously opens his airway with jaw thrust. You perform a primary assessment. So here we go. He's not moving. He's got massive facial trauma. He's responsive to painful stimuli. All right. So with the painful stimuli, we know that he's responsive to that. What else are we looking for as far as with a response with painful stimuli?
Does anything move?
Nerve function.
All right, nerve function. What did you say, D-Wayne?
Like when he responded to it, how did he respond? Did he open his eyes? Did he move a muscle? Did he move any arms, limbs?
Is he paralyzed?
All right, is he paralyzed? Also, but think head injury wise too. What is decorticate and decerebrate posturing?
Is he flexing inward or is he flexing outward?
Yeah.
Signs of TBI.
Signs of increased cranial pressure.
Right. And so that is a big concern of ours, right? And that occurs often in response to painful stimuli. Okay. You see blood draining from his mouth. His respirations are gurgling, slow and irregular, and his radial pulses are rapid and bounding, bleeding from the mouth, no other gross bleeding that you can see. When we say gross bleeding, we're talking about what can we see in large amounts. So how, number one, assessing this patient, is he in jeopardy as far as his airway is concerned?
Yes.
Absolutely. There's several things involved here. You notice massive facial injury, and he's gurgling, right? So you've lost stability of his face, of the muscles and the bone, and he's not able to control the fluids. He has 2 major airway problems that must be addressed: blood in the oral pharynx, which we're going to suction, and slow, irregular respirations that are clearly not adequate. You should suction and then try BVM in him. Would it be appropriate to intubate this patient?
Yes.
More than likely.
Yes, 100%, because the unstableness of this airway. Here's another thing to be thinking of. In my mind, I may have pertinent negatives right now for head injury, but, and this is a test question, This is something for you to think about. Anytime that you have enough force, enough injury pattern to cause substantial facial injury, you've got to think about the way that that force has been dispersed and the energy going through the skull to the brain, all right, through secondary injury. So what do we know about the muscle tone of the face if it's still intact, if he starts to have signs of head injury? He's going to do what with his teeth?
Clench them.
Clench 'em.
Absolutely. We're going to start seeing trismus, like Merry Christmas. So in that case, now you're looking at a situation where you've got a head injury patient that's probably going to need RSI. And so we definitely want to suction and check for a gag reflex. If no gag reflex, let's go ahead and maintain that airway. Let that be a priority. Okay. Okay. Did I miss something? Your partner is appropriately managed the patient's airway with BVM. You perform a rapid exam which reveals a hematoma to the patient's forehead, massive soft tissue trauma to the midface, unstable facial bones, and bilaterally angulated lower legs. So he's got a GCS of 6 breaths per minute and irregular. So that is a concern of ours. His pulse is 110 and his blood pressure is 120/90. So if he's in shock right now, he is compensating, but there's some other things that we are concerned about, such as the irregular respirations and things like that. How can facial trauma complicate the airway?
Unstable
You
maxilla.
wouldn't be able to get it field or BVM.
Yeah, the big thing there is the unstable maxilla and mandibular areas, which we depend on that structure to maintain a good seal, right? So this is going to be a difficult intubation as well. Do you think that this patient's in shock?
Yes.
Based off of what?
Vitals.
Well, his vitals weren't too bad, were they? As far as like what we would look at shock. But his skin is cool and clammy, right? And we have seen areas of bleed. The only thing this blood pressure is showing us is that he's in compensated shock right now, right? He's in shock. Although he has an altered mental status, it cannot be used as an indication of shock, as he also may have a head injury that could cause it. So here's another little FYI, little token of information. The single most important assessment finding in determining head injury is going to be level of consciousness. All right, not GCS, not AVPU. But level of consciousness. You apply full spinal motion restriction precautions, load to the ambulance. You and your partner agree that he should be intubated. Now, you did determine that he does have a gag reflex, and so you're going to do a MAI, medicated assisted intubation. Make sure, one of the things that I pointed out yesterday is to make sure you have looked at that airway before you start paralyzing, and you've got a plan, okay? Make sure that you've got a blind insertion airway device available too if you're unable to get that intubation, all right? And then make sure you hook that up to waveform capnography. So you got him intubated, his pulse is 90, his blood pressure is 110, he's still cool and clammy. He's pharmacologically sedated, so his GCS is going to be 3, which is the lowest that you get to. What else should you assess for the patient related to a possible head injury? And we talked about the posturing. If I say anoscoria, what are you looking for?
Unequal pupils.
Unequal.
Yep, unequal pupils. Looking for rhinorrhea or otorrhea, doing the halo test if you've got blood coming from the nose or the ears, so you start seeing CSF. And then what other findings related to facial injuries might you notice?
Bruising.
All right, bruising. What about
Ecchymosis.
all right, ecchymosis. What about if you had like I don't know, maybe fractures around the orbits as well?
Lefort fractures.
All right, Lefort fractures, zygomatic issues. You may see protrusion or retraction of the eyeball. Now, and to be fair here, all of these are very serious injuries, but they can be very, very distracting from the issue at hand, which is going to be airway management. Your patient's condition is clearly critical, so you ask one of the police officers to drive the ambulance to a trauma center located approximately 15 miles away to free up your partner to work in the back with you. En route, you get IVs, cardiac monitor, and it's difficult to assess the pupils because of orbital swelling, but you do manage to evaluate the right eye where there is less edema. His pulse now is 120, blood pressure is 108, he's intubated. His right pupil is dilated and sluggish, so it is dilated, but the fact that it is still even sluggish is a little bit better sign than it being just fixed. So you estimate 5 minutes, call report where the trauma team will be prepared for your arrival. Later in the day, you return to the hospital with another patient and inquire about your patient's injuries and his condition. Besides his head injury and tib-fib fractures, he had a Lefort 2, and he's been admitted to the trauma and is scheduled for surgery to stabilize his fractures. What's a Lefort 2?
Mid-facial fractures.
Fracture.
Yeah, so triangular shape. Yeah, mid-face maxilla fracture, which involves the nasal bone and inferior maxilla, at least a very unstable facial structure, usually with elongated appearance of the face and malocclusion of the jaws. Now, this is about a 3-minute video on Lefort fractures that I'm going to get this fella to talk to you about, all right?
Here we're looking
Can y'all hear
at Lefort fractures. These are mid-face fractures, and there are 3 categories of Lefort fractures, and collectively these constitute about 20% of skull fractures overall, and these are due to crush-type injuries to the anterior skull. So we see Lefort 1. Here we see Lefort 2, and then to our far right, we have Lefort 3. If we look at these individually, we'll begin with type 1. You can see where the red line is, and this would represent the line of fracture in the midface. Some considerations here to keep in mind is that this fracture does lie superior to the maxillary alveolar processes. This would be where the maxillary teeth are found in the maxilla itself. So we're looking at structures that would then span the nasal septum as you come across here, across the mid-face. And then this type of Lefort fracture may also involve the pterygoid plates that are features of the sphenoid bone. Type 2 Lefort fractures occur along the fracture line here, shown in red. Structures that are along this fracture line would include the posterolateral parts of the maxillary sinuses that would lie within this area here and over on the opposite side. The infraorbital foramina are in this area of fracturing. And lastly, the lacrimal or ethmoid bones may be fractured along the fracture line of a type 2. The third and final type of Lefort fracture is simply identified as type 3. This lies most superiorly with respect to the other two types, as we can see the fracture line coming across here. Horizontal fracture, upper midface, passes through, kind of hard to detect here, but will pass through the superior orbital fissures. Involves the ethmoid and nasal bones. Hard to see the ethmoid involvement in this view, but you can see involvement of the nasal bones. Would involve the greater wings of the sphenoid bone. And then lastly, which we can appreciate, it would involve the frontozygomatic suture. So that suture lies right in through here on this side and right in through the opposite side.
Okay. So the anatomic structure of the face, you've got your frontal and ethmoid bones, which are part of the cranial vault in the face. Then you got 14 facial bones, which form the structure of the face. So they're all individual bones. And when you have the different types of Lefort fractures, you're going to lose stability in those areas. With the type Lefort 3 fracture, it's also called a craniofacial disjunction. You've got a fracture of all midfacial bones, which essentially separates the entire midface from the cranium. So essentially, your whole face is disconnected from your bone. What arteries supply the blood to the face?
Maxillofacial. The anterior carotids.
Yep, your carotids. So the blood supply to the face is provided primarily through the external carotid artery, which branches into the temporal, mandibular, and maxillary arteries. Because the face is highly vascular, it tends to bleed when heavily injured. So you're going to see a lot of bleeding when it comes to scalp and facial injuries. Okay. What's a blowout fracture? Orbital blowout fracture. What?
Nick, it's kind of hard to hear you.
Is that better?
Yes.
Much.
I forgot I had a microphone. I forgot like I was a real like YouTuber here.
It's kind of like a it's kind of like a bunch of like shatter, like a shatter fracture.
I think what you're trying to say is like a shattered.
Socket.
Yeah. So an orbital blowout fracture, this is going to be where the actual orbit that protects the eye is blown out, which is going to lead to bleeding into the sinus, but it's going to lead to instability. It's going to lead to instability of the structures of the eye. Blood and fat are then free to leak into the maxillary sinus, and you may see really the eyeball moving around. So the insertion of nasal airways in the presence of midface trauma. Would nasotracheal intubation, blind nasotracheal intubation, would it be something that you would want to do?
Want to do? No.
Well, it is relatively contraindicated because of the instability. You really, if you've got midface trauma, your nasal passages may actually have been blown out, and now you may be inserting something into the sinus instead of going down the airway. It shouldn't or a NPA, nasotracheal intubation should not be performed in any patient with suspected nasal fractures or in patients with CSF or blood leakage from the nose or with any evidence of mid-face trauma unless it's absolutely necessary. What's anoscoria? And I asked you that earlier.
It's unequal pupils.
Yep. So David Bowie is pretty popular, or was. He had anoscoria, but he didn't walk around with a head injury. So this is actually a common finding in about 20% of the population. By less than 1 millimeter, and then about 4% have pupils that vary in size by more than 1 millimeter. But in the presence of when we think head injury, this is going to be a key finding because this could indicate that, hey, we actually have increasing intracranial pressure, and it's now putting pressure on the optic nerve and the optic and the oculomotor nerve, which the oculomotor nerve is what actually causes a contraction and dilation of the pupil. So when that increased pressure occurs, then you run into issues with that pupil doing anything. All right. What is your priority of care for a patient with dental trauma? So just because it's the teeth doesn't mean that it's not going to be a big deal. If you've got severe dental trauma, what is your priority of care? And guys, it's the same priority of care as it would be for any patient.
Airway obstruction.
Yeah, absolutely.
Airway
Airway management, if you have dental issues, if you have teeth knocked out, those sockets are going to bleed. All right. Suction should be provided, trying to remove the tooth fragments. Again, if it is forces strong enough to knock out teeth to cause facial damage, you need to be considering the energy transfer to the other vital structures in the head and neck. Okay. If profuse oral bleeding is present and the patient cannot spontaneously control his or her own airway, then you may have to RSI. When is it appropriate to remove contact lenses?
And there's something in the eye, like a chemical.
Only chemical burns. Only chemical burns. Why? Because we don't want the chemical to get in between the eye and the contact lens. And even then, if it's possible, try to get the person to remove it. Now, there might be other situations where it would be convenient for them to take their contact lenses out. You should try to get them to do it, but you don't do it. The only time it's acceptable for you as a paramedic to remove contact lenses is if chemical burns to the eyes are present, and then you should try to use like the little suction cup to pull it out and all that. All right. How do you treat an open wound to the neck?
Occlusive dressing.
Why?
So you don't suck air into the negative pressure of the veins.
Okay, so yeah, that's true. You've got major vessels running in the neck. So if you have a open injury to the neck, you run the risk of an air embolism. So you want to put a occlusive dressing taped on all four sides. I can tell you from experience that is really difficult. All right. Had a guy shot in the neck one time, and with the blood and with the sweating and all that, it is really difficult to do that. But you need to try your best. Okay. If you've got a patient that has a burn around the eyes, like a thermal burn, what is the most likely structure to actually suffer around the eyes from a thermal burn?
The tear duct.
Cornea.
No. Think about what your eyes do. If you had something coming towards you, what's your reflex?
The
Your
eye.
eyelids.
Yeah, your eyelids. Eyelids. Kind of a trick question there, but yeah, your eyelids are going to be the most likely structure to be burned in thermal burns to the eye. When should you remove a object impaled in the mouth or the face?
Only if
And
it's
it interferes with
Interferes
the
with the airway.
Interferes with the airway, absolutely. All right. When should you remove a foreign body in the ear?
Never.
No, it's really never.
Never.
There's some weird things that can get caught in the ear. I knew, or I heard of a call one time. It wasn't me, so, but I heard of a call one time where a person had a moth stuck in their ear.
My brother had one of those pop gun caps stuck in his ear.
Really?
Yeah.
Well, and I can't say nothing. I had glass stuck in my foot, and I never realized it. So, all right. So again, just with your facial injuries, though, remember, it's very vascular, so you've got to try to control bleeding the best you can, and while maintaining airway. Okay. So that's really it on what I had for face stuff. Are there any questions on that?
No, but I have an easy way to remember Lefort fractures if anybody's interested.
I am.
We typically called them mouth, mask, and goggle fractures.
Makes sense. Lefort 1's mouth.
Correct. Yeah, it's or boxer fracture. That's what one is, and 2 was typically if somebody got hit in the face when they were wearing a mask or something that falls along that lines, and then goggles were like skiing accident was common for Lefort 3.
Mm-hmm. That's a good way to remember it. What'd you say, mouth, mask, or goggles?
Correct.
Cool. All right. Well, moving right along, I feel like we've had a pretty good review on some of this stuff today in a short time. So, y'all like the discussion question format a little bit better? Like getting the information to you? I think it utilizes our time a little bit better than me just trying to read a PowerPoint.
Yeah.
All right, so I want to get to head and spine trauma, really focusing on the neuro aspect, and I want to talk a little bit about intracranial pressure and stuff like that. So again, we're going to look at the paramedic aspects of some of this stuff. All right. On your first day of work as a paramedic, you're dispatched to 9121 Floyd Trail for an aircraft crash. If this is your first day as a paramedic and you're responding to an aircraft crash, that might be an omen.
It's the last day.
En route to the scene, dispatch informs you that a witness saw a single passenger gyrocopter fly into some power lines, then plummet to the ground. If you don't know what a gyrocopter is, it's just really just kind of like a one-person little helicopter type thing. However, the witness did not see whether the patient was unconscious after the crash, as it landed several hundred feet away in a field. You arrive to find a small rotary wing aircraft that has crashed in the middle of a large field of tall grass. You see power lines lying across the craft and an entrapped female occupant who appears pale. A technician from the power company determines that the power lines are no longer energized, so you approach the patient. So here's your gyrocopter right here that is crashed. Okay. So you get to the patient. She's anxious. All right. That's always going to be a key finding there. All right. You could chalk that up to, well, she just crashed her aircraft, or you could chalk that up to it might be early signs of something. She's alert. Her airway's patent, calling for help. Her breathing's rapid and deep, and she appears slightly pale. What's your first concern arriving on scene?
Scene safety.
Yep.
The power line's dead.
Yep, and they confirmed it. I trust the power company over, just some jackleg firefighter like some of y'all are. But
Hey now.
That's
I'm
when
gonna tell you.
the fire in first.
I'm gonna tell you, Dwayne. You come up to me and tell me those power lines are dead. I'm gonna be like, Dwayne, I need to
Go
hear
touch
from
it.
the power
Prove
company.
it.
Yeah.
I'll prove it. I'll just go touch it.
Mm-hmm. There's many factors which can create an unseen safe with dealing with a downed aircraft, and this is something we just don't think about, but it is a combustion engine, so we do worry about fuel leakage, things like that. You can assess your patient using binoculars at a safe distance. You should attempt to gain as much information regarding her overall condition, taking note if she is silent, shows signs of distress through either posture or facial expression, or has visible skin signs. A vehicle-mounted loudspeaker system or bullhorn or hand signals can be used to communicate with the patient. All right. What additional resources, if any, would you request and when?
Helicopter.
That's kind of morbid, ain't it?
Public Works.
Yep, Public Works. I'm getting the fire department out there because they can help.
I said helicopter is in air medical.
I know. I'm just saying that's kind of morbid on that. She probably don't want to be riding no helicopter right now, but I know what you mean.
You probably have to knock her out to put her on one other one.
Yeah. Yep. So given a mechanism of injury and other factors, what injuries do you suspect? So is this a substantial MOI?
Yes.
Yes.
Absolutely. What are you worried about with her?
Spinal injury, head injury,
Multi-trauma issues.
multi-system injuries.
Yeah, so I mean, she had forces applied to her all over, so we are worried about that. Our main ones right now: central nervous system, head, spine, and internal injuries. At this
Could have
point,
electrical burns.
yep, she could have electrical burns. She could have thermal burns. At this point, the patient's alert enough to call out for help. Her color and rapid breathing indicate that there may be internal chest or abdominal injuries, but that may also be a result of pain or anxiety. So further assessment will be essential. You can obtain a wealth of information from the patient's posture, guarding, and facial expression. The patient has a mechanism of injury consistent with a spinal column compression fracture. She seems to be attempting to stabilize her lumbar spine through her posture and her use of self-splinting. So you get additional help to aid you in safely treating and transporting. After the known hazards have been addressed, you approach the patient, and her name is Lynn Chase, to begin your hands-on assessment, but as you near her, you notice a strong odor of gasoline. Right now, her pulse is 110. She's cool, slightly pale, and dry. She's alert to person. Her BP is 130/74. Respirations at 36, and she's 98%. Given the information thus far, what are your priorities?
C-spine, airway.
C-spine, airway, and probably going to be rapid extrication since we're
To
smelling
get her
the
away
gas.
from that smell of gasoline.
Absolutely.
Gasoline.
Um,
Have a lawnmower engine on there?
probably.
You'd be surprised.
Patient's past medical history will give you an overall sense of your patient and her ability to compensate in the presence of blood loss. So, I mean, you do need to get history as you can. All right, firefighters aid in decontaminating the patient as well as applying spinal precautions. She finds it difficult to lie flat on the board and tells you that her back hurts a lot. She reports, "I feel better if I hold it." She denies any weakness, numbness, tingling in her extremities. Vital signs, her blood pressure is going up, 142/76. Look at this, though. Her level of consciousness, she's alert but lethargic and much slower to respond to questions with slurred speech. She's cool, slightly pale, and dry. Her respirations now are 36.
ICP.
Right. You're right, and that answered that question. What could cause a patient's decrease in alertness? She may be in shock from internal injuries or a head injury. You still have to use her differential. What vital sign findings can help you determine the cause of the decreased alertness?
She's hyperventilating.
Okay, hyperventilating, but look more at your objective stuff here. What would you look at to help you determine, is this shock versus head injury?
Blood pressure.
Her blood pressure, her
Pulse
blood
rate.
pressure and her heart rate. Absolutely right. So instead of in shock, where her blood pressure would be expected to be going down, hers is going up, and her heart rate's coming down.
ICP.
As soon as your patient's packaged, you begin to transport to the closest trauma center, which is approximately 22 miles away. You establish vascular access, cardiac monitor, reassess your patient. Her mental status continues to deteriorate so that she only responds to painful stimuli. Look at her blood pressure now and look at her pulse. And now she's got irregular respirations. She read the textbook, didn't she?
Cushing's drag.
Cushing's triad. You're concerned about her level of consciousness, and now you really consider the possibility of head injury. So using your differential diagnosis, you're able to probably rule out shock at this time, right? The patient was alert when you arrived, but don't know if she lost consciousness at the time of impact. So your differential now includes subdural or epidural hematoma, and you prepare to treat symptoms of increased intracranial pressure. How does the presentation of subdural hematoma differ from that of an epidural hematoma? So if, and y'all, I'm assuming some of y'all haven't read this yet, but you do need to know this, all right? Subdural and epidural, they have very differencing vital signs, kind of like a hemorrhagic shock versus ischemic shock. A subdural hematoma progresses slowly as it is a venous bleed with an acute bleed showing signs and symptoms within the first 48. The patient may have a fluctuating mental status and may develop focal neurologic signs such as slurred speech or unilateral hemiparesis. An epidural hematoma is usually due to the tearing of the middle meningeal artery, so you're going to have faster bleeding, often presents with immediate short-term loss of consciousness followed by a return to fully coherent state of consciousness. This is called the lucid interval. Write this down, go back and look it up. Lasting anywhere from minutes to 24 hours. However, the intracranial pressure is not done building up, and so as it continues to build up, your patient will go back into coma. In some cases, a patient with an epidural bleed will either not have a lucid period or may not have an initial loss of consciousness, with consciousness loss only after the intracranial pressure bleeds. So it's not possible to determine the exact etiology without getting imaging and stuff like that, but one thing that you can be sure of is that this is being caused by some type of head injury, okay? And in her case, her mental status is slowly deteriorating. But for epidural hematoma, I do want you to write down that lucid period and look that up because that is part of the textbook assessment, okay? So, and we talked about this, what pathology do the current vital signs suggest? And somebody said Cushing's, because we're trying to overcome the intracranial pressure by raising the blood pressure, and raising the blood pressure, we're trying to raise the MAP so that we can get an increase in cerebral perfusion pressure, okay? What are the most important interventions you can perform to maintain cerebral perfusion in this patient?
Oxygen, fluids.
All right, and that's really it. What?
Alignment, maybe?
What do you mean alignment?
By the neck and head.
Okay, all right, definitely. And you want to try to have these patients in, if it's possible, yeah, you're going to have her aligned, but you got to figure out a way to try your best to have her in a little bit of an upper, maybe at like a 30-degree angle to help with some of the pressure in the head. So 3 factors will cause cerebral perfusion pressure and cerebral blood flow to fall: hypoxia, hypercarbia, and hypotension. Therefore, the most important prehospital interventions for a brain-injured adult with increased intracranial pressure include constantly maintaining adequate oxygenation and ventilation and maintaining a systolic blood pressure of at least 90. To do so, you must ensure the patient's airway remains patent and monitor oxygen saturation and blood pressure closely. End-tidal CO2 monitoring can assist you in approximating the patient's partial or arterial CO2 level, which should be maintained at a range of 30 to 40, which is slightly decreased from normal because we may adjust the ventilation rate to higher, right? Elevating the head of the stretcher or backboard to a 15-30-degree angle can also be beneficial. And if you start seeing seizures, treat quickly with sedation. So you learned that you got her to the hospital and all that. You learned that She experienced a subdural bleed that necessitated ICU admission. She probably had a brain drain put in. She also had compression fractures of the lumbar spine, but no spinal cord damage. She underwent surgery to stabilize the fractures and is slowly recovering. It is expected that her injuries will not limit her quality of life, including an ability to function as a pilot in the future. So you did save her life. So in her case, identifying the difference between shock and head injury probably made a huge difference. All right. So moving on really quickly, when we talk about head and spine trauma, our main issues that we're really concerned about is insult to the nervous tract, the central nervous system, including the brain and spinal cord. Why? Because insult and injury to those neurons will cause permanent damage. They do not replace themselves. You got two primary divisions of insult to the central nervous system, and that's going to be your head trauma, traumatic brain injury, or spinal cord injury, or SCI. The structures that make up the cranial vault, which include the structures that make up the face that we had talked about earlier. Then you also have your frontal bone, which makes up a large portion of the front of the cranium, the parietal bone, occipital, sphenoid, and ethmoid bones. The brain connects the spinal cord through a large opening at the base of the skull called the foramen magnum. Now, they say it's a large opening until you start having a lot of pressure on the brain. One thing I wanted to make note of is the fact that the cranial vault is very small, and there's only about roughly 2 millimeters of space between the brain and the skull. With that being said, the brain doesn't have anywhere to go if it starts to swell, okay? The floor of the cranial vault, one of the things I just wanted to mention, I'm not going into all the particulars here, but the floor of the cranial vault is very, it's irregular. It's not smooth. It has several appendages, several little points on there, and it could actually lead to injury in the brain when you have issues like sudden deceleration and things like that, okay? This is also, the floor of the cranial vault is also where you would have like basilar skull fracture, and this is why if you had basilar skull fracture here, this is why you would have CSF leaking, because it would leak into the sinus, because just below that is your sinuses, like right in there, okay? So your brain, the only reason why I'm going back and even mention this right now is simply for the fact that you've got three main portions, the cerebrum, the cerebellum, and the brainstem. The cerebrum is going to be the area of higher functioning, and it includes the different lobes, your frontal lobe, your temporal lobe, occipital lobe, and your parietal lobe. This explains, because each one of those lobes have different aspects of control, right? So this explains why stroke or injury to the brain can cause different manifestations, right? Because it all depends on the area of the brain that's affected. Then you've got the cerebellum, which is located beneath the cerebral hemispheres. It's often called the athlete's brain because it's responsible for maintaining posture, equilibrium, and coordinating your skilled or your motor movements. And then, of course, you've got your brainstem, which I've heard it referred to as the most primitive part of the brain, where it can control just the autonomic functions and the things that are vital and crucial. And so this explains why you could have a patient that doesn't have spinal or brainstem injury, but they have cerebellar or cerebral injury, and they can become a complete vegetable, but still maintain respirations, heart, and all of that stuff, okay? What are your meninges?
Fingers and toes? No? I
That's
don't know.
phalanges.
Yeah, that's phalanges or digits.
The
Meninges.
meninges is like the curves in the brain.
The nerves that go up to the on the back of your spine and your lead to your brain. I know they're inflamed in meningitis.
I think Eric was saying something, but your meninges are your protective layers that surround and enfold the entire central nervous system. Specifically the brain and the spinal cord, and you've got several layers of this. The outermost layer is a strong fibrous wrapping called the dura mater. So your dura mater, also known as the tough mother. I ain't lying, it's the tough mother. Shut your mouth. The dura mater covers the entire brain, folding into form the tentorium, a structure that separates the cerebral hemispheres from the cerebellum and brainstem. The dura mater is firmly attached to the internal wall of the skull. All right, so think about this for just a minute. I mentioned a epidural and a subdural bleed. An epidural bleed is going to mean that the bleed is what?
On the outside of the dura mater?
Yep. And then a subdural is going to be
Inner.
below the dura. All right, so that's where the dural comes from. The second meningeal layer is a delicate transparent membrane called the arachnoid. So some patients may have a subarachnoid bleed. It's so named because the blood vessels it contains resemble a spider web. The third meningeal layer, the pia mater, also known as the soft mother, is a thin, translucent, highly vascular membrane that firmly adheres directly to the surface of the brain. So again, I kind of took for granted that y'all would have known that, seeing as how we've already went over meningitis last week or the week before. All right, so the meninges, that's very basic anatomy there. You need to know about that. You've got meninges covering your brain and your spinal cord, okay? So your spine itself consists of 33 vertebrae divided into 5 sections, right? With your spinal cord going down the middle, all right? And the area of spinal cord injury will affect the overall issues that the patient may face, all right? The spinal cord transmits nerve impulses from the brain and the body. At the base of the skull, it separates into the cauda equina, which is a collection of individual nerve roots. You got 31 pairs of spinal nerves, and they emerge from different segments. So when you're studying, you need to look over the spinal nerves and your spinal tracts, which is found on page 1718. What are some risk mechanisms that of injury that may indicate a spinal injury? Some high risk mechanisms.
Fall from a distance greater than 20 feet or so.
Right. And I'm not going to sit here and read all these because it's listed in your book. But if you look on page 1720, nope, that's not it. That's head injury. That's in here somewhere. But page 1720. High velocity crash greater than 40 miles per hour, unrestrained occupant of moderate to high speed MVC, vehicular damage with compartmental intrusion, so on and so forth. These are all going to be high-risk mechanisms of injury, which suggests possible spinal injury. Whenever you suspect a spinal injury, you should assess for spinal injury to determine whether the patient should be placed in full spinal immobilization. Also, with these high-risk MOIs, they should be transported to a they should be transported to a trauma center, right? When should RSI be considered for a patient with a spinal injury?
They have a gag reflex.
Okay, all right. I'm thinking more along the lines of like,
Yes, less than 8.
Whatever injury affects the diaphragm.
yep. That's it. When the spinal, I'm talking more spinal injury here. When it affects their normal processes of breathing, all right, based off of the level in which the injury has occurred. So in a patient with spinal injury, a definitive airway with an advanced airway device should follow the placement of any temporary airway device. If the patient is awake with an impaired airway or has a GCS of 8, less than 8, intubate, consider drug-assisted intubation.
Did L7 go to heaven or something like that?
Oh man, I just had it in the tip of my head and I was going to say it, and then
C7 go to heaven, didn't it?
yeah.
What if it's like a C1, C2, C3 suspected fracture? Because that could affect the brainstem.
I'm kind of losing you there, Sir Catherine.
She's crossing into Florida where there's no service.
She's going. Hey, you're gonna be mad when you know that I haven't heard anything you just said. Hey, wow, you just changed position. Hello. Hey.
Now?
Yep, we didn't hear a single thing you just asked.
Okay. Well, what if it's like a C1, C2, C3 fracture? And would you want to consider airway since that could affect the brainstem, which could affect your breathing?
If you see signs of airway compromise, now are you talking about fracture of the vertebrae, or are we talking about actual insult to the spinal cord? Because at C1, C2, C3, if you have insult to the spinal cord, you're going to have pretty much full paralysis, and you will have to manage the airway. We'll just have to come back to this. And she gone.
Yeah, that ain't working.
Yeah.
I was just saying, like, if fractures were like possibly, or deformation that looks like it could be a spinal cord injury as well. I don't know. I just
Not working.
That area,
her and Jacob.
She's passing Jacob's house.
Yeah, that's it.
Okay, never mind. That's later.
Okay. All right, good. All right. When you get real good service, we'll talk again. When providing manual ventilations, when would hyperventilation be considered?
Brain bleed?
Yeah, when you suspect, not just brain bleed and even not with TBI, but when you suspect cerebral herniation, right? Remember, the idea behind that is hypercapnia is going to cause vasoconstriction in the cerebral arteries, right? And so the idea behind that, which is a really terrible way to try to manage increasing intracranial pressure, but is try to or hypocapnia, I'm sorry, causes vasoconstriction, is to try to wash out some of that CO2. And so again, when we say hyperventilation, it's going to be 20 breaths per minute. But your key here is only if signs of cerebral herniation are present, and the fact that that you've got end-tidal CO2 really to manage that. So, and then unresponsive patient with 2 or more of the following: asymmetric, unequal pupils, or bilaterally fixed and dilated pupils, posturing, decelerate posturing, or no motor response to painful stimuli, or a GCS less than 9. Okay. What is the single most important sign that you can detect when you assess the severity of a brain injury? And I told you this earlier.
Mental status.
Level of consciousness. Level of consciousness. All right. So you do want to get your AVPU and your GCS. The GCS, though, is not necessarily telling you consciousness. The level of consciousness indicates the extent of the brain dysfunction. A change in this level is the single most important sign you can detect. I've said that about 4 times, so I bet you there's a test question on that. All right. What about using longboards? Pros, cons, controversies.
There's been studies that says that long backboards can cause more injury.
Absolutely.
There's also findings that there's not actually any like clinical evidence that they help.
Right.
Well, my personal opinion is if I roll up on a wreck and you've been out, and I've been told by bystanders and cops that you've been out walking around for a good 5 to 10 minutes before we get there, and then all of a sudden you see us and it's, oh, my back hurts, I'm not putting you on a spine board.
And you're going to set yourself up for some litigation.
I can't help it.
The guidelines for long spine board is that if they have suffered a significant mechanism of injury, we need to further evaluate. If they are complaining of any neck or back pain, we are going to put them on a backboard. That's protocol there. But you are right. The long spine board has been seen to have not really helped, and in some cases caused some issue. If you can clear them and not put them on a spine board, that's probably your best bet. You can still maintain a degree of cervical motion restriction with a C-collar and all that. But at the end of the day, we do know that it has never been immobilization. It's been motion restriction because it doesn't completely immobilize. All right. Real quick with head injuries, you got 2 general types of head injuries. I'm not saying brain injury here. I'm saying head injury. Closed head injury, which is associated with blunt trauma. You see brain tissue exposed. You'll have open skull fracture, and then open head injury associated with penetrating mechanism of injury or brain tissue might be exposed there. I'm sorry, with closed head injury, that's going to be unexposed, and that's where you may have like linear skull fractures or depressed skull fractures. With open, you'll see brain tissue exposed and open skull fractures. Now, there's a couple of different types of skull fractures. I'm not going over those today. Go through and read them. Look over those. 2 classifications of traumatic brain injury. You've got your primary injury, where the injury is sustained directly and its associated structures are directly from the force on the impact on the head, whereas secondary brain injury refers to the after effects of the primary injury, which includes abnormal processes such as cerebral edema, intracranial hemorrhage, increased intracranial pressure, cerebral ischemia, hypoxia, and infection. Secondary brain injury can occur anywhere from a few minutes to several days following the initial injury. Why is that important? Because they may have suffered a brain injury based off of the mechanism of injury that we've seen, but they may not be experiencing the full-blown effects of the inflammation at this moment. Okay? Most Common causes of TBI is going to be MVCs. In this picture right here, showing the coup counter coup, which is a front and rear type, which the passenger's head hits the windshield on impact. The brain continues to move forward. It hits the front of the skull, and then it hits the back of the skull. Okay. Normal ICP. What is the normal intracranial pressure? I'll give you a hint. It's not very high.
0.
It's higher than that.
14.
All right. It is from, you're in that range. It's 5 to 15 millimeters of mercury. All right. Why? Because there's not a lot of room. There's not a lot of area for the brain to really have a lot of pressure. What's your normal mean arterial pressure? Normal.
60.
80 to 90.
It's 85 to 95. It's 85 to 95. Somebody said 60. That's the MAP or the map that is required to provide a minimal perfusion to the brain. All right. So a couple of terms. Well, I'm not. A couple terms for you to go back and look over if you're not familiar. Your cerebral perfusion pressure, which is the difference between the mean arterial pressure and the intracranial pressure. Your cerebral perfusion pressure equals MAP minus ICP. Your MAP is the diastolic blood pressure plus 1/3 of the pulse pressure. All right, which your pulse pressure is going to be your systolic minus your diastolic. So the way you would get your MAP would be essentially you would do systolic minus diastolic. Well, here, let me just write it here. This is one I wish I had. So you would do, hey, guys. You would do systolic blood pressure minus diastolic blood pressure divided by 3, all right? And that plus your diastolic blood pressure will give you your mean arterial pressure, all right? So for instance, let's do normal blood pressure. So 120 over 80 equal, or 120 minus 80 equals what? Because I'm doing a 120 over 80.
40.
All right, so 40 divided by 3 is what?
13.3 repeating.
All right, 13.3. All right, so what's my diastolic pressure? 80, right?
Yes.
So in my normal blood pressure of 120 over 80, my mean arterial pressure is 93, okay? So what that tells me is that I can actually have a lower blood pressure and still maintain some sort of cerebral perfusion. All right. But blood flow to the brain must be maintained at a constant level. So if the ICP goes up and you've got to maintain cerebral perfusion pressure, what has to go up?
The mean.
The mean. So your MAP has to go up if your ICP is going up, your MAP has to go up to maintain cerebral perfusion pressure. If we were in the classroom, I could work out this on the board to show you how the same pressure is going to be different and how you're going to need higher blood pressures, as in the number in the brain is what is controlling all of this. Okay. So, a couple of things the body does to combat increasing intracranial pressure. It gets rid of CSF and venous blood from the cranial vault, so that's going to move fluid out. And then this keeps the ICP within normal limits in the early stages, and then we have to start compensating. We start having to have more of a mechanical compensation. Does that make sense? We're having to force stuff up, okay? So at first we can decrease the pressure by removing content, but as that pressure continues, there's a barrier that we've got to overcome to get more blood in there, okay? This is called the Monroe-Kelly doctrine. All right. There's two types of herniation. You've got your cerebral herniation in the foramen magnum, or you've also got an uncle herniation syndrome where you've got your dura here, and you start having blood fill up there. So instead of the pressure pushing down or from this way or that way, you've got blood building up here. But here's the thing. What do you notice about this side of the skull?
There's an open skull fracture.
Right. So in the case of increasing intracranial pressure and an open skull fracture, that might actually help the patient because it gives the stuff a place to go. Is it great? Absolutely not. But what do they do? What's one of the things that they do for treatment of increasing intracranial pressure in the hospital with head injury? They remove a portion of the skull, right? You ever heard of that? They remove a portion of the skull, and sometimes they'll freeze it, or sometimes they will actually implant it into the abdomen so it'll stay alive. But it actually provides an out for some of that pressure, okay? You need to know your early signs of intracranial pressure increasing so that you can manage that quickly. But you also need to know the difference in your early signs and your ominous signs. When you start seeing Cushing's triad, you're getting a little late into the game there, okay? Remember on the scenario that we talked about just a minute ago, I said, hey, she's anxious, so that's a sign right there. Now, is there anything we could have done about that? No, other than just getting her to the hospital, right? But
Knocking her out.
We could knock her out, but that's really still not going to help the inflammatory process. Get what I'm saying? So there has been studies, not with, I don't think as much with the brain injuries, but with spinal injuries, where patients get loads of steroids to help with the inflammation and to stop the inflammation process. And they're even like in the NFL, there's studies where if they suspect spinal injury, they put them in an ice bath to help the swelling and stuff like that. But in the head, when that swelling starts to occur, there's not a lot that you can do other than get them to the hospital really quickly, okay? And then manage airway, of course, okay? And then, of course, know your posturing, your decorticate, and your decelerate, all right? I just mentioned these. I'm not going through all of these different injuries, but what I do want to mention is that, like with cerebral concussion, there are some specific things that you need to know about cerebral concussion, such as it can cause memory loss. You may have amnesia. You may have antegrade amnesia. You may have, moments of lucidness and then unresponsiveness. All right. A concussion is something that needs to be seen about. On page, let's see, 1738 to 1740, it gives you a bunch of information on your concussions, and it even has this a concussion concussion action plan for athletes and a CDC return to play program where, right now concussions is a really big deal because they're seeing a lot of after effects from pro athletes that played for years, and now they're starting to see the effects of that. And so they're really wanting to focus in on lessening the impact of concussions. All right. And then you've got second impact syndrome. And this is going to be, they have another issue, and this is just post concussion. And then DAI, diffuse axonal injury. There's several levels of DAI. Now, do not take concussion lightly, because it can be a very serious injury. You've got mild, moderate, and severe diffuse axonal injury, and this is where axons diffusely are affected. And so, so read over that, all right? All of your type bleedings here, all right?
Can't hear you, Nick.
Can you all hear me now? All right. There's some specific signs and symptoms that are associated with epidural and subdural, and even some of these others here, where epidural has that lucid period by textbook, not always. All right. And then subdural, it can last a little bit longer over time. So elderly patients are one of the higher populations to be affected by subdural hematomas. They, you know, grandmother falls and she's okay right now, but in the next day or two, you start seeing signs and symptoms of altered mental status, things like that. That happened to Steve's mom when she was living several years ago. Mr. Simpson, my boss, his mom, that she fell, and then she ended up, I think they took her to the hospital and they didn't see anything, because a lot of times these brain bleeds are not going to show up within the first 24 hours on imaging. All right. Now, again, y'all are going to go into details on all of these when you do your prep work, okay? As far as assessment and management, severity of injury, there's several things that are going to affect the severity of injury, and that's going to be the forces used and the area affected, things like that. Level of consciousness, one of the very big things that you want to consider there. Thermal management. Patients with brain injury and spinal cord injury, they may suffer from hyperpyrexia, meaning that they may get too hot. They lose control of those temperature regulating mechanisms. I also threw this in right here. Pharmacological therapy. Lasix shouldn't be used, and the idea there is that, hey, we could pull fluid off the brain, but it's a loop diuretic, so it doesn't necessarily work. Mannitol is actually a different type of diuretic that works. It helps pull glucose off, and it helps pull fluid out through a different mechanism. Mannitol is used in head injury patients, but you don't usually see that in the field, okay? But it is a diuretic. Benzos should be used for seizures. You want to treat seizures immediately if they occur, okay? With spinal cord injuries, there's very limited treatment other than we get them to the hospital, okay? Specific injuries, these are going to be like force injuries, like by the different forces as far as flexion, rotation, things like that, distraction, hyperextension, and by the different mechanisms, they're going to cause different types of injury, not only to the vertebrae, but also to the spinal cord as well. Now, as far as the tissue of the spinal cord, it is neuro tissue, so it can suffer things like a spinal concussion or a spinal contusion. And then, of course, if you have a spinal laceration, you're going to be affecting nerves, okay? As far as secondary spinal cord injuries, this is going to occur after is a progression after a primary spinal cord injury. And this is going to occur usually due to the inflammatory processes and things like that. What I want you to do is when you're reading these, you will find each one of these, you need to write down in your prep work the specific signs or symptoms of each one. Like Brown-Séquard syndrome usually occurs after penetrating and appears to with functional hemisection of the cord and complete damage to all spinal tracts on the involved side. So basically what I'm saying is, like with Brown-Séquard, you're going to have a hemi deficit, meaning that one side of the body is going to be affected. All right. So look over those types of injuries as well. Okay. Rapid extrication for a patient who potentially has a spinal injury. Do you just, you know, with reckless abandon, just go snatch them out of the car?
No.
So rapid extrication is a process of manually stabilizing and moving a patient from a sitting position into an immobilization device without the use of like a vest type, like a KD or something like that. So basically what we want to do is try to maintain safe practice as far as manually stabilizing, but move them more quickly. All right, so we may have to do more manual stabilization before we can actually get them like on the backboard or something like that. And again, this is only in times when you have the patient is in immediate threat. Okay. As far as pharmacology for spinal cord injury, spinal cord injuries have been shown to be a little bit responsive in the acute phase to corticosteroids, like I was mentioning earlier. Pain medication may be necessary. Usually, we're not going to see steroid use, though many of the spinal organizations now recommend against steroid use in the management of acute spinal injury. So again, for us, it's going to be pain management if they are in pain, immobilization, get them to a trauma center. Okay. As far as complications, of course, aspiration, we want to be watching for their respiratory status and make sure they can control their respiratory status. All right, and one of the last things I want to talk about before we go, autonomic dysreflexia. Autonomic dysreflexia, which is a just this massive response. All right, you're going to see some questions resulting with this. Potentially life-threatening, most commonly occurs with injuries above T4 to T6. Patients present with a massive uncompensated cardiovascular response. In this case, this is patients shoot. In this case, these are patients that have spinal cord injuries, and you're going to start seeing not just as far as cardiovascular response, as far as like dysrhythmias, but you're going to see a blood pressure shoot to over 200. You're going to see maybe even vagal compensation, bradycardia and vasodilation, and peripheral and visceral vessels above the lesion. So basically, what I want you to know with autonomic dysreflexia is that if you've got a patient that has a spinal injury and you see that, hey, their blood pressure shot out of the roof, they're having cardiovascular issues, and they may even be experiencing hyperpyrexia or increased body temperature, this is probably going to be because of autonomic dysreflexia, which is a complication of certain spinal cord injuries. Okay? Read over non-traumatic spinal conditions. The big thing with non-traumatic spinal conditions is it's going to be debilitating back pain that is not due to trauma. So the main thing with this is that if a patient, which a very large amount of patients do call for debilitating back pain, if they call you and it is a issue such as degenerative disc disease or spinal stenosis, something like that, do not place them on a backboard, but be very empathetic with their pain and understand that their pain may not be able to be managed at all, and you need to, they've called you as a last resort to get them to the hospital. Okay, and that's kind of my review of everything. Felt like that one probably went the best out of all of them I did so far. Are there any questions? All right. Well,